Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
I'm a firm believer that technology is the answer to all difficulties facing radiology today. There's almost nothing you can't effect if you try hard enough.
Using technology to solve operational challenges in radiology is one of the primary themes, in my opinion, of Dr. Ben Strong's career at vRad. For those of you who don't know Dr. Strong, he is currently the Chief Medical Officer at vRad. For those of you who don't know vRad, which I'm guessing will not be many, at least for listeners in the United States, vRad is one of the largest providers of radiologic services in the United States and one of the leaders in teleradiology worldwide. Dr. Strong, who completed medical school at the University of Arizona in Tucson, internal medicine residency at Dartmouth-Hitchcock, and then radiology residency and a MSK body MR fellowship, both at the University of Arizona, has practiced for 3 years as an emergency physician, and in radiology practiced 2 years in private practice, 2 years as an assistant professor at the University of Arizona, and then 18 years at vRad. Ben has therefore seen and experienced many facets of medicine and has extensive experience in radiology. My goal with this interview was to provide myself and each listener a wider understanding of what the practice of teleradiology entails. I invited Dr. Strong to conduct this interview with me, and he graciously agreed. I did not, nor will I receive any compensation from vRad for this interview. Know that this is perhaps the longest episode of the Radiology Review podcast to date. This was not necessarily by design, but rather is a result of me finding much of this interview to be potentially valuable to listeners. I do encourage current residents preparing for board exams to make sure and listen to the final 5 minutes of the episode to learn about free educational board review and board review competitions sponsored by vRad that you and your residency program can participate in if you are interested. I want to make listeners aware that the show notes for this episode contain links for 2 relatively inexpensive books that are very pertinent to our interview today. The first by Dr. Atul Gawande, The Checklist Manifesto, that is referred to by Dr. Strong. The second is by Dr. Long H. called Search Pattern, A Systematic Approach to Diagnostic Imaging, which is also pertinent to our discussion of the importance of search patterns in radiology. One final note is that there is some mostly mild random popping that I hope listeners won't find too bothersome. Perhaps imagine that you are listening to this interview on a vinyl record, because to my ear, that is how this sometimes sounds. The audio quality is, thankfully, more than sufficient to understand what is spoken. So, without further ado, here's my interview with Dr. Benjamin Strong. Hi, Ben. Welcome. Thank you for speaking with me today and for taking the time to have this interview.
Absolutely, Matt. It's a pleasure to be here.
You were recently in Utah speaking to and teaching some of my own residents, and I heard really good things about it. The first question I want to ask you is, visiting residency programs and speaking to residents something you do frequently?
Absolutely. Actually, I wish I did it more. A lot of academic centers, residencies are a little resistant to external lecturers, and sadly, that actually limits the number that we can do. The lecture schedule on many residencies is packed, and slots are fought over, apparently, with some ferocity. Working your way into the lecture schedule actually is more of a challenge than you might think. If I had more invitations, I would do it quite a bit more, because it's something we truly love, and we think that our emphasis on education is unusual. We have access to so many resources, so many interesting cases, that it really is a shame we can't get out there more.
Well, I think it's a fantastic thing you do, and I do understand that residency curriculum time is limited and very valuable. But again, I heard great things from our residents about your visit, and hopefully getting this out there to other residents to listen to can maybe prompt a few more invitations, because I heard it was simply excellent. And I have one other question. Did you have any time to ski or snowboard while you were here with us in Utah?
Unfortunately, no. I was pretty much in and out. But I do snowboard here in Arizona, and I had gone just the previous weekend. So that got me through.
Well, that's good to hear that you're snowboarding nonetheless. Next time you're here with us in Utah, I hope you have some time to hit the snow here. It's been an exceptional ski and snowboard year for us with all the snow. But that's not what we're here to talk about. We're here to get to know you and vRad better and learn more about what vRad is and does and your philosophy and how you're structured. We also will discuss radiology training and get some of your thoughts and advice for radiology residents and fellows. We'll talk a little bit about the current state of radiology and the radiology workforce. We'll discuss a little bit about AI in radiology. And we'll close by me asking you for at least one bold prediction for the future of radiology. So let's get to know you and vRad a little better. For our audience who may not know you, Ben, let me tell them that you are currently the Chief Medical Officer at vRad, which is, I imagine, a really exciting and rewarding position to have. And vRad is one of the major providers of radiology services in the United States. Can you give us a summary of your career from medical school to where you sit today? How did this happen?
I'll try to be brief, but I did take the long way to get here. Initially, out of medical school, I was going to apply to radiology. Mm-hmm. I remember I filled out 15 applications to radiology residencies. And then I had a crisis precipitated mostly by the input from my old attendings, who I called for reference letters. And one of them actually said, "Gee, I always thought you'd be a real doctor." That's the kind of contempt you ran into.
Unfortunately, I heard some of that as well, yes.
Yeah, and I'm sorry to hear that it hasn't gone away. This, of course, is more than 30 years ago at this point. So, but that shamed me effectively into doing internal medicine. I thought, if I'm walking down the street and see some guy grab his chest and faceplant, I won't know what to do. And that seemed to me to be the essence of why one went to medical school, was to be able to handle situations like that. And so I decided, I guess I'll go into internal medicine. So the funny thing is, I did not appreciate the value of an internship, because halfway through my second year of internal medicine residency, I looked around and said, well, gosh, this was stupid. I am competent at those things, and I really wish I'd done radiology. And so I applied to radiology programs and got in, and spent my third year of residency as sort of a pariah, having turned my back on internal medicine. After that, I actually had to kill a year before starting my radiology residency. So I worked as an ER doctor in a remote emergency room for the Indian Health Service. And I have many hair-raising stories from that, of course. The only doctor for an hour's drive in all directions. It was a really educational experience. So that actually then rolled into my radiology residency, and I spent a period of time with significant overlap. I worked a total of almost 3 years as an ER physician, and 2 of those years overlapped again with the first 2 years of my radiology residency. So following that, I actually signed up for an MR Body and MSK fellowship. And no kidding, true story, I called my parents to tell them that I was signing up for my 8th year of postgraduate medical education. And my mother cried. She thought I would just never go out and get a real job. Those were her words. So after that, I went into private practice. Spent 2 years in a private practice. Well, I chose my private practice based on 2 things. I said, I am not going to go east of the Mississippi, and I am not going to read a physical film. So I thought the practice that I find that tells me I can have a purely digital workflow will be the one I take. So I did luckily find that practice. There weren't many at the time. This would be about 2001. And I worked 2 years in private practice. So after that, my frustrations with workflow, I would have to cite as the main reason I left private practice and went to vRad. And I had a transition period there as well, while I was getting credentialed and licensed and relocating because, of course, joining vRad gave me great geographic flexibility. So I returned to Tucson, Arizona, and I worked as an assistant professor at my old alma mater for a period of 2 years. And that again overlapped with vRad as well. I actually went a 15-month period during that time when I worked every single day.
Wow.
Weekends, holidays, everything. I just loved radiology, and there was an opportunity to do it pretty much constantly. So after that, I basically have worked now for vRad for 18 years. And I was initially one of a very small cadre of daytime radiologists. vRad mostly had been emphasizing after hours emergent teleradiology. And I became essentially the cleanup guy that would do what was left over from the night before, help cover vacations for radiologists around the country, and do some of the stranger, more esoteric studies for various facilities that didn't necessarily have the specialty bandwidth to cover them. It was a very challenging and very interesting time. And ultimately, it resulted in my getting 50 state licenses, which I still maintain today. Actually, I should say, which vRad still maintains today. At the time, there was a lot of competition in teleradiology. And I was very concerned that teleradiology be a success in general and specifically at vRad. It was a job I loved and I wanted to keep it and I wanted it always to be there. And so I worked extensively with the other departments at vRad, and we were a beautiful combination. They were willing to teach me, and I overcame my physician's arrogance to finally recognize that people that aren't doctors do have bodies of knowledge that are greater than yours, and that they can impart a great deal of knowledge to you. And so I worked with sales and marketing and software development and compliance departments across vRad, and they really embraced me as well. So ultimately, that led to my becoming the chief medical officer almost 10 years ago now.
Thank you for telling us your story. I presume that your training was at the University of Arizona. Is that correct?
Predominantly. I went to medical school at the University of Arizona. Then I did my internal medicine residency at Dartmouth, at the Dartmouth Hitchcock Palace of Glass and Green Steel. Having had enough of that weather, I returned to Arizona to do my radiology residency and fellowship.
Yes, I love Tucson, Arizona. I love the weather there. I was also a resident and graduate of the University of Arizona, and that program is near and dear to my heart, so we have that in common.
Oh, that's wonderful to hear. It's a great program. It actually collects the semi-retired greats of radiology from around the country.
Yeah, I benefited from a lot of that national expertise that does consolidate in Tucson while I was a resident there as well. And my time at that program was really just fantastic. You must have been one of the first employees at vRad, is that correct?
I was not the first, but I was early on. I was approximately the 25th radiologist that they hired.
How was vRad conceptualized from the beginning? Do you have some insight into that? How did vRad start itself?
Yes, Sean Casey was the neuroradiologist who was the founder. And I have to say that everybody had figured out that teleradiology was at least possible at this time. PAC systems were out. Mostly you were reading off an intranet within the hospital, and people hadn't quite mastered the transfer between institutions. Bandwidth wasn't great, compression algorithms were not reliable, and so it was challenging, but all the same, everyone realized it could be done. So the idea that I could be reading these studies remotely, that was old. In fact, I'll back up and say, I always remember the first time I saw an X-ray on a computer screen. I was a third year at Dartmouth. It was 1995, and I knew I was going into radiology. And I looked at that screen, and my first thought was, I don't have to be in a hospital. Other people had different first thoughts, but that was mine.
Interesting.
So again, that was an idea that was not hard to hit upon. But what Sean Casey did is he looked around during his neuro fellowship at the University of Minnesota, And they had requirements for him to read nighttime studies, cover ERs, outlying facilities, things like that, which they do to a lot of fellowships, and I'm sure that still goes on today. So he was working plenty of nights, and he looked around and said, well, I should probably form my own company to do this because they clearly have a need. And that's what he did. When he graduated from his fellowship, he founded the company Virtual Radiologic, and his first client was the University of Minnesota. So the thing that Sean did that was intelligent and that I still respect to this day was not that he had the idea of teleradiology, but that he took the steps necessary to make it a reality. He founded a company. In fact, he owned a house at the time. He was financially ahead of me, that's for sure, at the time, at that level of training. But he owned a house, and he actually mortgaged his home to get the seed money to hire an executive team and found this company. He went out and he created an executive team with a chief of operations, a chief of technology, a chief financial officer, a real corporate structure. And that's what separated him, I think, from all the others who'd had the same idea but couldn't make it a reality.
I love that entrepreneurial vision, and to believe in yourself so much that you're willing to sacrifice something like your own home to put that on the line for an, at that time, unproven concept is really impressive. I love that entrepreneurial spirit.
It was gutsy. It was quite impressive. And I'll give Sean this too. As I mentioned, I spent a segment there initially with vRad, working every day for 15 months. Sean Casey worked 364 consecutive nights in the first year of vRad's existence.
Wow.
And the only time he said it was the birth of his second child that broke his streak. So he really put in his time, and he really had the foresight to know that creating a company was the way to get this effected. And I remember actually he came to my house for dinner one night many years ago, and my wife prompted our son to say, "What should I do to be successful?" And my son was maybe 5. And I always remember Sean said, "Found a company and sell it." It was his mindset all along.
And we can now look back with the perspective of decades to see that his vision really did pay off. Can you help us understand what the current scope of vRad is? Specifically about how many radiologists does vRad currently employ? How many studies does vRad interpret each year? Can you give us a little bit of those details?
Absolutely. We are in all 50 states, plus we do read for a number of foreign entities as well. I actually just looked at our 2022 stats. In 2022, we had 497 radiologists read at least one study. The other day, I sent an email to all of our radiologists, and it went out to 583 radiologists. We always have some people coming in, some people on their way out, and that accounts for the difference in those numbers. But under contract right now, and with email access, we actually have 583 radiologists. But actively reading radiologists, probably about 500. We read about 6.3 million studies a year, and we cover approximately 2,100 client facilities around the country.
Wow.
The math is a little bit tricky, but I am certain we read more than 40% of the after hours imaging in the country, probably closer to 45%.
That is remarkable to think about. How many of those reads are prelim versus final reads?
Well, the prelim read, thankfully, is actually on its way out. It is a dinosaur looking for a tar pit, as I like to say. It really came about for logistic purposes 20 years ago. 20 years ago, we didn't have the technological capability to look into an on-site PACS system and actually see the imaging timeline and access those prior studies. In addition, there were challenges with regional payer enrollment. You have to enroll with all your different payers and when you're working in any one area. And that was too challenging to take on when we were small. So the prelim arose across all of the teleradiology practices. I would add, there were probably 50 tiny teleradiology entities in 2004 when I started that were all competing, and everyone basically with a a modem or a PC would declare themselves to be a teleradiologist. That was a really challenging time. But prelims were spread across all of them because nobody had these capabilities. Now we have an automated query retrieve that displays the entire imaging timeline on every patient. And we've actually written our own software programs to effect and monitor the regional payer enrollments. So we have overcome the obstacles that really led to the prelim being so common in after-hours imaging. So over the 20 years, we have watched the prelims decline. They really are inefficient from a radiologist bandwidth perspective. They are probably more costly than a final, and they create difficulties with patient management, I think, with some disparity between readings, which you're always going to see when two radiologists read one study. So the prelim is dying a slow death. I would say it reduces by about 3% a year. It's the percentage of prelims in our practice. And we are now down to close to 25% prelim. And that's been a process that's been going on since 2005. I read the first final for vRad in February of 2005. So prior to that time, we were 100% prelim, and now again, about 25%. And that's a number I expect to continue decreasing. I don't believe it's going to go completely away, but it'll probably get down to 10% in the next 5 or 10 years.
That's really interesting. I had no idea that prelims were on their way out. In fact, I also did not know that vRad reads approximately 40 to 45% of all overnight studies in the United States. Is that correct?
I believe so. Again, it's a little hard to determine exactly what the total number is of after hours, but that is my best estimation.
Do you ever sit there and think about how many individuals that is impacting? I mean, that's really remarkable when you think about it.
My wife is tired of hearing how often I think about it. It truly is a remarkable scale, and to have been here the whole time during the creation and growth of this practice, it's mind-boggling.
From my perspective, vRad has grown very quickly to date. What is your perspective regarding further growth for vRad?
Well, it didn't go quickly for me, Matt. I can say that. It's been a long haul. We had a period of really relatively slow growth initially. I guess I would break things into 3 segments in our history. So we've been around since 2001, and during the first third of our existence, we had very slow growth. Again, we were competing with a whole bunch of like-sized, small teleradiology outfits trying to make it. And I think the thing that really separated us out was the fact that we built our own platform. We have always had a significant number of software engineers in our employment, and they created the beginnings of our integrated platform that I think were the thing that differentiated us from all the others. We then had a middle third that I would probably call the Nighthawk phase. We were a publicly traded company for a period in the late aughts, and we were ultimately taken private by a private equity company that bought us for $300 million and that bought our main competitor, Nighthawk, for $180 million. And we were identical in size in terms of the number of radiologists we had, around 150 each, and the number of client facilities we had, which was at the time about 1,000 each. And so the two companies were smashed together, and that created really quite a lot of chaos and churn. I honestly would never relive it if asked to. We actually had a period of about 3 years, then reimbursement reductions and things hit at the same time. This is about 2010 at this point. So we actually had a period where we had maybe 2 or 3 years where we actually had negative growth. But then we got back in stride and have grown significantly ever since on an annual basis. I would tell you that going forward, I'm very pleased about this. We have much better control of our capacity and demand ratio. The various corporate overlords that run companies like ours, and we've had 7 different ownership structures, one thing they all have in common is their desire to see growth. And so it's kind of a battle to keep growth at a manageable rate. And that's been a battle we haven't won every single time over the years. But it's one that we're now firmly in control of. We have enough experience and enough historical data to prove to anyone coming along that growth for growth's sake and growth beyond your capacity to manage is not desirable. So we've settled down to a nice, slow, single digit, probably low single digit, 4% or so rate of manageable growth, and I hope to see that continue forevermore. That's something a practice like vRad can deliver on. People that come in and demand 10% growth and whatnot, we can show them, again, that that's a bad idea. It's someplace we've been and don't want to revisit.
Interesting. And emergency radiology, from my perspective, has been and maybe continues to be the bread and butter of vRad's practice. Is that accurate?
Absolutely.
Do you read outpatient imaging studies? Can you give us some perspective there?
Yeah, absolutely. Well, it certainly was the reason we were founded. It was our initial mission, and I would say we haven't deviated much from it. We primarily are an emergency after-hours teleradiology practice. Now, that said, we have ventured into other venues, and sometimes successfully, sometimes not, and we have found our sweet spot with regard to daytime outpatient imaging, and that is the large municipal or regional multi-specialty type of practice that is heavy in outpatient imaging. Those we do wonderfully with. And so we have a few of those relationships in large cities around the country, probably 4 or 5 of them at this point. And so now I would say we're at about 15 to 20% normal outpatient daytime imaging. And then somewhere 80 to 85% is after hours emergent teleradiology.
And can you share your thoughts on vRad expanding into subspecialties that have been historically perhaps less amenable to teleradiology, such as breast imaging and nuclear medicine?
Well, actually, we've done pretty well with both breast imaging and nuclear medicine, with some caveats, I suppose. I'm a firm believer that technology is the answer to all difficulties facing radiology today. There's almost nothing you can't effect if you try hard enough. So from a breast imaging standpoint, we've done wonderfully. We have our own cadre of dedicated mammographers. It's a segment of our practice that shows probably the greatest controlled growth. We've assigned lead interpreting physicians to our various mammography facilities. We've enabled face-to-face interaction with both the technologists and even the patients for counseling sessions by using simple video chat. So that has worked out very well and has not been much of a problem. Again, the ability to acquire and archive for ourselves prior images was critical there, right? So there were challenges in the early days that we have overcome. Nuclear medicine is a little more difficult. We certainly never cover a nuclear medicine facility that doesn't have its own physician on site, mainly because of RAM licensure requirements. We've seen a definite decline in emergent nuke med studies. In my old days, we did plenty of VQ scans and HIDA scans and bleeding studies and those sorts of things, and many of them have been replaced with other imaging modalities. So they're becoming less and less common. So the after hours market for nuclear medicine is not raging. You know, the one thing I would say, so there aren't too many specialties that have thwarted our efforts, but I do have to say pediatrics is one of them.
Huh. And why is that?
You know, there's always a bit of a chicken and egg phenomenon in any imaging, where when you're trying to take on or create a new line of imaging, you have to get facilities that will send those studies. But at the same time, a facility won't send you a study unless you've got the dedicated radiologist with the appropriate specialty training to read it. On the other hand, it's hard to hire that specialist unless you've already got the appropriate imaging in the pipeline. And so which one you manage to do first? You either hire a pediatric radiologist and make them read adult studies while you ramp up your implementation pipeline, or you contract with a pediatric facility that has to have adult radiologists read for them until you can hire and credential a pediatric radiologist. For some reason, that problem is exacerbated in the pediatric world, possibly because there's so few pediatric radiologists. But we have taken a run at creating a pediatric service line many times over. And at this point, I've kind of given up and have decided to leave it to others.
I would not have guessed that you would have that challenge there, but it does make sense how you explain it.
Yeah, that's probably the one that I'd say has been the most difficult for us. And we've been very successful with all the other types of specialty imaging, including things like stroke imaging, which can be a very complex workflow. The one thing I would add is I have discovered that it's not that easy or desirable to go after what I would call niche types of procedures. Coronary CTA, virtual colonography, even high-resolution lung screening. In the old days of vRad, we always thought, oh, there's such cachet to those, and we want to tell everyone we're reading them, because what if someone says, hey, can you read our colonographies? If we say no, they'll go try to find some other provider. The real truth is that doesn't bring in other imaging volume. It doesn't impress the lay public enough that they begin throwing money at you in fistful. It just doesn't inspire the way you might think. And it's not a large enough volume ever to warrant your efforts or to cause a client facility to look elsewhere for coverage. If there is one pursuit I wish I could take back and regain all that energy and effort put into it, it would be that, is chasing these kind of niche procedures.
Let's switch gears and get some of your thoughts on radiology residency and fellowship training. Many radiology residents and fellows will listen to this podcast interview. I want to make sure and get to this question because I do think it is important. And my question is this: what is the most meaningful professional advice you can offer current residents for their future career in radiology?
Well, I think it's actually pretty straightforward, Matt, and I've alluded to it previously. I truly believe that technology is the single best solution for almost every problem confronting radiology today. And I think that's going to be more and more the case in the future. And so I would emphasize that above all other things. I think that the practices that emphasize technology, its acquisition and utilization and integration, are the ones that will be successful and the ones that will honestly be the least frustrating to work for. I think most of a radiologist's professional satisfaction is going to stem from those just basic workflow issues. And that is the best way to identify the practice that will deliver on that, to look for technological savvy.
Are there any skill sets pertinent to being a successful teleradiologist that are not currently taught in radiology residency or fellowship programs?
Well, there isn't too much difference in my mind between teleradiology and on-site radiology, at least in terms of the execution of the actual job. You do learn to read a little more into a little less information, perhaps, and you may have a broader potential differential in mind for any given study, because again, you're just one step remote from the whole process. So I always told our teleradiologists, why do you need a clinical history at all? Just assume that every study is a patient who's been in a car wreck, has a fever, and has a history of metastatic cancer. And then you'll be fine. So that's the one difference, I think, for teleradiology. In general, I wish I saw more emphasis in both on-site and teleradiology on the utilization of a search pattern to interpret radiologic studies. I think that some people are exposed to it, but it is not a universal component of people's educations. And I can tell you that after, I think I was on the vRad QA committee for about 12 years, and after looking at all those QA cases, I came away convinced that about 90% of all radiology errors result directly from failure to adhere to a regimented, methodical, repeatable search pattern for that procedure.
You know, Ben, I couldn't agree more with that. Being in academics, I often talk to residents before they start call. They are always nervous. And the advice I always tell them is that the best thing you can do to be prepared for call is to have a solid search pattern. I tell them that the misses you will make will likely not be due to a knowledge gap, but it will simply be that you didn't look for that finding, and that the end of maybe a year on call, you will find that your search patterns have really been solidified. I do think that an emphasis on search patterns is something we should probably focus on more in residency training, at least at the programs I've been at and taught at. And I really appreciate your perspective there because I couldn't agree more.
That's great to hear, Matt. You're giving good advice. I'll throw in a book recommendation, Atul Gawande's Checklist Manifesto. It doesn't actually address radiology, but it seems like it does. It will speak directly to you and to this issue. It's an impressive work. I really encourage people to read that book and to apply what it says to radiology. The simple fact is a complex cognitive task, such as reading a CT scan, just requires a regimented approach. I often joked, one of my old chest attendings told me once, the best distance to read a chest x-ray from is you reach out and touch the film, and then you lean back and put your hands behind your head. And that's how you could determine the perfect distance from which to read a chest x-ray. If all you did was read one view chest x-rays, you could, after 20, 30 years of it, you could just let that image kind of flow over you and passively take it in and do probably fairly well. But the complexity of modern imaging just does not lend itself to that sort of approach, right? When you think about misses today, you will miss something if you don't have the right image up, if you are not scrolling at the proper speed, if you don't have the right window setting, and if you don't have the right thought in your head, for that matter, you will miss that finding. And so I think the complexity of imaging has created a need for greater emphasis on that approach, that being the search pattern approach.
Now, I want to ask another question that I personally think is really important for us to discuss, because I want to make sure that we are sending accurate messages to our trainees. Specifically, being in academics for some number of years now, I've heard on a number of occasions, even a few times within the last year, academic radiologists send some caution to trainees that entering teleradiology straight out of radiology residency or fellowship may not be ideal for reasons that typically center around maybe a lack of mentorship in the teleradiology environment for newly minted radiologists, or perhaps an inability to get an additional opinion if a new radiologist is looking at a particularly challenging imaging study. Are any of these concerns valid? And especially, what is your perspective on newly minted radiologists entering teleradiology straight out of training?
Well, that is a good question, and it is a legitimate concern in teleradiology in general. It is actually not the case at vRad. First of all, I would say I didn't receive any mentorship when I went to private practice. I had no interactions that I would have called mentorship. I had some collegial interactions with other folks, but I did not have a role model or a coach of any kind. And it didn't seem to be my lack of receptiveness. It just seemed to not be part of the culture at all. So I think the idea that any other practice you go to will have mentorship is probably illusory. I would also add that interpersonal interactions on site are not the highest quality of interpersonal interactions. You're dealing with technologists you didn't hire, with partners you didn't choose. There are all kinds of interruptions and distractions. I've listened to people yell at their spouses on the phone in the cubicle next to me. I've listened to people plot their fantasy football rosters. All interpersonal interaction is not necessarily desirable. And if you take those energies and put them into spending time with your friends and family, people that you did choose and do choose to spend time with, I think it's much better spent there. But to move on to why vRad is different, we recognized that, hey, perhaps isolation or the lack of mentorship might be an issue. We realized it a very long time ago, and we built appropriate systems and processes to accommodate that. So when we hire a new radiologist, we assign them a radiologist advisor. They help with the workstation training. They go through your practice cases that we give you to grade your reports and give you tips on that. They're there to review any quality assurance issues that come up during your first 3 months, and they're always available for questions. So we have a mentorship program actually formalized at vRad. In addition, we have a teaching file built into our system so that anyone can save any study to a vast repository where we then select those cases for our educational materials. It's a reference for our radiologists, so there's always a vast array of studies that can be referenced for educational purposes. We have embedded StatDX into our system, which the folks at Elsevier told me we're the only practice in the country, right? Because, of course, we have the software engineering capability to do that. So we have StatDX right there, ready for reference, that gives you a 0.5 CME per search as well. So we have built all kinds of processes into our systems that enable the radiologist to interact, to address this mentorship issue, and for that matter, the interpersonal interaction issue. And the other thing, we have a consultation engine built into our platform. So if you have a question about a study, you can simply hit the consult button and you will be given a list of every radiologist that's online at the time. I mean, if you get on at midnight on a Friday night, there will be at least 200 radiologists also online, listed with their specialties, and we also even list the number of consults they've taken in the last few hours so that you can see if someone's been carrying more than their load. And so you can send out invitations. You can send out as many as 6 invitations at once. And those people all get a nice baby blue tab and a soft ding. And when they have the opportunity, they can click on that tab and take the consult. So you rarely wait for more than a minute. And when someone accepts your consult, it will open a mutually controllable viewer window where both of you can annotate, scroll, and chat back and forth. So it's easy as scrolling up to the level, putting an arrow on the thing and saying, what is that? And so people are very collegial at vRad. There's no such thing as dumping on one another because we pay on a productivity basis. And so if you don't read a study, someone else reads the study and they get paid for it. So there isn't any of the acrimony that can arise from unequal contribution, which I saw as a common issue with the cultures on site.
Yeah, I like the example also how you use your systems to provide consultations and help radiologists be able to do their job better. That does provide some reassurance in my own mind that new radiologists entering vRad do have a helpline readily available, it seems. If they run into a case that's challenging, you guys certainly, it doesn't sound like, leave them on their own to figure it out without any support. So that's great.
Yeah, it is neat. And I would say, too, that the younger generation just loves vRad. They thrive here because they understand the advantages of technology. They seek it out. And they also are of a mindset that they want flexibility of all kinds, geographic flexibility, scheduling flexibility, workflow flexibility, and we're able to deliver on that. So I think there are a lot of positives to just coming straight out of training and going to teleradiology. In fact, a lot of the complaints that I hear from the older radiologists that come to us, probably the most common regret is they all say, I wish I'd done this sooner. So you can't do it any sooner than right out of training. And then you'll have no reason to look back with regret.
And along those lines about living life without having any regrets later on, what is your advice for current radiology trainees in terms of selecting their first job straight out of training? How can they get it right? It's a big decision. What advice do you have?
Well, it is a big decision. And I truly feel that teleradiology is a great first option. Again, you don't want to have regrets. But I would add a couple more practical things. I think one is I think there will be a greater division between diagnostic and procedural radiology as time goes on. Especially since COVID, there's been such a shift towards teleradiology and a much broader acceptance of it as a legitimate entity. So I think that it's going to separate from the procedural aspect significantly. And I think that when you look for a job in this day and age, you should probably be deciding for yourself which of those you want to pursue, because you're going to have to pick one path or another in the coming decade. I also think that it's advantageous. For one thing, it enables teleradiology much more, right? It's, again, more broadly accepted. It'll be more widely utilized. But I also think that was one of the things that drove me from private practice as well, is the expectation that you perform both your diagnostic duties and your procedural duties simultaneously in your on-site workflow. I found that terribly distracting, constant interruptions with regard to your ongoing procedures, and always trying to just knock out one or two more diagnostic studies before the next biopsy comes. It was terrible, and I always felt that I did a less than good job at both because I was required to divide my attention and energies. And so if you can just focus on one aspect or the other, I would say do it. I haven't held a needle in 16 years now. And the one time I have held a needle in the last 20 years was to put an IV in a guy on a plane. So I don't miss that aspect. I find the diagnostic to be the cognitively challenging and professionally satisfying aspect of radiology that I'd always wanted. I actually don't have more advice on picking your first job, but I do have advice on picking your second job.
Okay.
One thing I've noticed is that all the practices that are offering any of these various models, private practice, academics, teleradiology, they are very much the same. Now, I will make the exception to say vRad is entirely different from every other teleradiology practice out there. But generally speaking, with that exception, I view the basic models of academics, private practice, and other teleradiology practices as being fundamentally similar. And so if you find yourself unhappy with your first selection, whichever of these it is, change models. If you join a private practice and say, I don't like this private practice, we're treated unequally, other people are making more for less effort, the efficiencies of the workflow are abysmal, don't think that you can find a private practice that solves those problems. You might think you did, but you'll go to that other private practice and 2 years later, you'll look around and say, well, I'll be. This is just like it was. They present themselves differently. They hide or shield their flaws in different ways, but ultimately they are fundamentally very similar. So if you find yourself in a private practice where you are unhappy, then I would say try academics or try teleradiology, right? But don't move around within the same practice model because you'll probably find the same problems.
Yeah. There's a large percentage of radiologists who do switch jobs within their first 3 years after training. That did apply to me as well. And I can say that it is the second job where you have a lot more insight into what you actually like in radiology and what you're truly looking for. So that makes sense to me. I do want to circle back really quick and ask you, do you think when you say that in the future diagnostics and procedures will increasingly unbundle, does that apply to breast imaging too, or is breast imaging perhaps an exception?
Yeah, I would agree with you, Matt. I think that probably those will remain bundled, as you say, in mammography. That does make a lot more sense.
So let's spend our remaining minutes talking about the state of radiology on a more global perspective and perhaps not specific to teleradiology, but I think you are in a position to really share some valuable insights into what the current state of radiology is. So first, do you believe that there is a current shortage of radiologists?
Oh, absolutely. It is beyond shortage at this point, beyond paucity, probably to dearth of radiologists. It's impressive, and I don't think it's going to go away, and I think it's going to worsen over the coming years.
Yikes. That's something that keeps me up at night, to be honest, because there's simply an increasing mismatch each year between the work to be done and the number of people available to do that work in a high quality way.
Yeah.
To improve shortages in the radiology workforce, you obviously can train more radiologists. There are certainly some constraints that exist in the pipeline to do that. You can have existing radiologists work longer hours. And I think that has, in my view, been happening since I was a resident and beyond. I am seeing longer work hours be part of the typical day of a radiologist in many instances. Or you can help the existing workforce become more efficient. Now, I've seen a few webinars that vRad has put available online. It's been really interesting to learn more about the efficiencies you've introduced into practice. It seems to me like vRad has a very strong focus on efficiency. I've seen examples of your PACS system, which I believe is customized and maybe proprietary to your practice.
Yes.
A lot of discussion about radiologist support that helps minimize non-interpretive tasks. I've seen discussion of the operational systems that match studies to radiologists throughout the country. And obviously, if you are working from home, you also negate having to commute, and that provides more time for radiologists to read studies. My question is, how far has vRad come in terms of achieving maximal efficiency? Do you think you're about there? How much work is still ahead to get there, if not?
Well, the question of maximal efficiency, it's funny, it's actually relative to what technology is currently available. So if you had asked me 15 years ago, in fact, I remember saying this in the late aughts, we're there. We are as efficient as you can get in the creation of a radiology report, in the interpretation of a radiology image. We are there until someone figures out how to take it straight from my brain. It couldn't be more efficient. That was by using our integrated system. And you're right, we write all our own software systems. So our PACS and our RIS and our platform in general are all in-house maintained and built. And so it gives us a great deal of control. Our ability to customize is truly extraordinary. So we had built a system that allowed program mouse buttons, and we even have our own proprietary input device. I use voice commands to manipulate images. I use foot pedals to do so. I use all four extremities. I often joke I feel like I'm riding a motorcycle or flying a helicopter when using our workstation. So at the time, 15 years ago, I really thought we'd hit maximal efficiency. How could you do it faster or better? And then along came natural language processing. And that enabled us to format our reports after the dictation, not dictating into a template, which I think is horribly misguided, but formatting our reports after dictation and putting them into a standardized template. Natural language processing enables prompts based on the content of a report. It enables direct suggestion of reference materials. It enables you to drop specific recommendations that are standardized directly into your reports. It allows us to identify critical findings and facilitate calls, even automate calls to the facility based on the content of a report. It was extraordinary, the things that opened up for us. So there we were. I thought we were probably at 90% of maximal efficiency in 2008 or 2009. And all of a sudden along comes NLP and we're knocked back to 50% because look at all we can build now. Right? We've even built a summarization tool of prior reports where the natural language processing goes through, pulls out the relevant findings, and gives our radiologists a bulleted list of the things that it found. So extraordinary advances. And again, that put a dent in us, right? It knocked us back to maybe 50%. Then we worked through that, got back up to 80 or 90% of maximal efficiency using NLP, and along comes AI image detection, right, which enables us to kind of create a safety net, a backstop for significant pathologies. And the possibilities there opened up again. We can actually use AI to identify the number of views in an X-ray study, for instance, and that helps us with establishing that the proper procedure was ordered before a radiologist even sees it. All kinds of things you can use that for. So I would say, again, we were knocked back to 50% maximal efficiency and are working our way back up again now by applying AI alongside of our NLP.
I am noticing a very recent shift, in my opinion, in academic practice in terms of academic departments starting to embrace daytime teleradiology as a viable option to meet clinical imaging needs. Do you have any thoughts on academic radiology departments employing daytime teleradiologists? And can that be an effective model for resident staffing and education?
Well, I would say I haven't seen clamor from the academic centers, and I've always attributed that to the fact that they have an army of residents that they can squeeze ever more work out of. And so coming to teleradiology for assistance in coverage isn't very commonplace. I would say academic facilities are underrepresented in our client base. That said, we do have a few, and we have great relationships with them. But I would say they typically are using us for clinical coverage and have not embraced us as educators, which I think is actually too bad because we've built the software, the platform features that would be required to educate residents, to have them basically create a preliminary style report that could then be reviewed by the attending and signed off on and graded for that matter in our system. And we've created the system whereby we could then have sign out sessions with the resident at the end of their shift. So that actual infrastructure is in place at vRad, but I've only seen it utilized once, and I think kind of half-heartedly. Because the residency was not willing to make some alterations in their own approach that would have made that system work much better. The issue was simply ultrasounds. The academic facility where we were doing this, where we had, this kind of overreading process in place, it was all torpedoed, undermined by the fact that the radiology residents had to perform the ultrasounds themselves after hours. So they were constantly being pulled away from their work list. And then it complicated everything in terms of, well, has this study been read by a resident yet? Should we wait, or should we just have our attending level physician read it? And there were all kinds of confusing issues with regard to critical findings reporting. Did the resident call? Do we call? Do both of us call? Again, I think the on-site facility could have been a little more flexible, and we could have made that succeed, but that's as close as we've gotten. Otherwise, we cover academic facilities, but they use us, for their outlying outpatient clinics, ERs, things like that, where they just don't have resident coverage. And so it's pretty much like a normal teleradiology relationship.
Let's spend our last few minutes discussing more specifically AI in radiology. What is vRad doing to employ AI to help your radiologists?
Well, we're doing a lot of work. I think the thing to point out is that you can't really do much in AI until you have taken the first step of building a natural language processing engine. With NLP, you can then pull specific reports that are describing the specific pathologies you want to build algorithms for. So once you do that, then you can pull those images from your archives. You can run them through a computed neural network and develop an algorithm to identify that pathology. Then you're able to apply that algorithm to every incoming study. We can use that information to expedite studies that are deemed positive for life-threatening pathologies and bump them to the top of our work list. You can also then use your natural language processing to look at the report the radiologist created and establish whether or not that specific pathology is being described. When we find a discrepancy between the content of the report and the conclusion from the algorithm, we shunt that to a third-party radiologist, a deputized member of our quality assurance committee, to adjudicate and to resolve that issue. And we're very close to real time at this point. So that's how we're currently using it. We take those then disparities and we feed those back into the computed neural network to hone its performance. So that's the basic approach that we're using for AI. The other thing I would add that I think is very important is that we are focused. We are intelligently choosing the pathologies for which we build algorithms. vRad has a very robust QA oversight program. We know exactly what types of pathology are missed and how frequently. We also have 20 years of experience in medical malpractice, right? At our scale, we have a better understanding of what types of studies result in medical malpractice indemnities than most practices could. In fact, I gave a lecture on that at the University of Utah recently, Matt, and the title of that lecture is 137 Years of MedMal Experience, because our 4-year assessment of MedMal cases that had closed is the equivalent for an average practice of 137 years of experience. So we've taken that data that we alone are in possession of. We know what are the most frequently missed things. We know what are the most disastrous things to miss. And we use that data to specifically choose the pathologies we're going after with the process I just described.
How is AI use at vRad likely to change over perhaps the next decade?
Well, I think we're going to be rolling more towards the operational issues, helping to identify specific study characteristics, helping to facilitate their distribution, helping to facilitate the radiologist reporting, things like automated insertion of measurements, automated calculations, say, of an intracranial hemorrhage volume or a right-left ventricle ratio, those sorts of things. The bottom line is this: we have had great success at building pathology-specific algorithms, looking for a single specific pathology. Ultimately, the global diagnostic AI, I think, is a long way off. I think that will ultimately be the accumulation of thousands of single-purpose algorithms. So it is not our goal to do that. It's our goal to find those things that we know are most commonly missed or are most devastating when missed, and to provide a safety net for our radiologists to not miss those things. Ultimately, it is not our goal to build an algorithm that says, aha, this is a case of pulmonary amyloidosis. That is really not on our roadmap. It may be that someone does develop that in the coming 5-10 years, perhaps, but it's not really our goal. So I see, after locking down the severe life-threatening pathologies, I expect we'll move more into radiologist efficiency and operational advantages from AI.
Interesting. Do you employ your own computer scientists?
We do. We have actually, I think, over 60 software engineers in various realms throughout vRad. We write our own programs for everything: the credentialing and licensing, our financial programs that pay the radiologists, that bill the clients. We have written our own study distribution algorithms, which are patented. We actually hold over 20 patents, most of them for software features and workflow improvements. So we've written all our own programs, and they're all integrated together, and that's really a large part of why vRad is so efficient.
I really appreciate that approach of using AI to help us with those diagnoses that, if missed, will cause most patient harm. I'm excited to see what you can continue to do with development of this AI going forward. Let me ask the final question, and this is something I've asked of others that I've interviewed as well, and with the caveat that nobody has a crystal ball and we can't hold you accountable for this in the future. Can you perhaps share some bold predictions for the future of radiology?
Bold predictions.
Yes, bold predictions.
Well, I don't know how bold they are, but I do see a greater corporate roll-up of radiology practices. I think this is going to continue. It's gone on for some time already, but you see the extent to which emergency radiology, cardiology, and a variety of other specialties have been sucked up into the corporate world. And I see that happening in radiology and continuing. So that may not be the greatest news, but it's not terrible news. Radiologists, doctors in general, are not the greatest businessmen. And did you really go to medical school to manage real estate holdings and hiring and firing of nurses, aides, techs, imaging equipment purchases, and the like? That's really not our forte. And so I do see the role of the radiologist shifting to a much more clinical role in the future, And I don't think that's necessarily bad. It will come with still a very reasonable compensation and a great deal more flexibility in terms of scheduling and workflow expectations. So I do think that is inevitable, though, and that is a process that will continue. It's going to slow here for a few years based on the economy, but I don't think it'll ever end. That's one thing. The other thing I'd say is I've been shocked at the lack of progress from most practices around the country with regard to the adoption of technology. And I know you all may be thinking, but they all have PACS. Well, that's a very minimal first step. Mm-hmm. What I see in practices around the country is a digital duplication, reproduction of the analog workflow they previously had. I've got this program for my work list, and I've got this program for my dictation, and I've got this program for my PACS. And that's fine, but it's still fragmented, it's still segmented, and those entities are not integrated together. So one of the big next steps that has to be taken is a unified work list. I know most practices cover multiple facilities, multiple hospitals, but none of them talk one to the other. And so that doesn't garner any operational advantages. Until you have a unified work list, you can't equally distribute the workload. You can't apply the same kinds of templating or AI algorithms or any other processes to your studies universally. And I think it's a big stumbling block. And so when I say look for technological savvy, that's what I mean. When you look at practices that have made an effort to integrate the various segments of their digital workflow into a real digital workflow. And one of the first steps in doing that is creating a unified work list. And I'll take that even further. I think that is going to be a huge differentiator amongst practices in the coming decade. Because when I look at AI and practices' efforts to implement it, I see a lot of people who are trying to run before they can walk. Because why would you bother to try and apply AI algorithms to a fragmented study volume that's isolated in this hospital, that imaging center, et cetera? It becomes too difficult to manage. Unless you have a unified work list and have all your procedures running through the same process, a bottleneck where you can apply your AI algorithm to every relevant study, you're never going to succeed. And so I think this drive to acquire and apply AI may have the fortunate benefit of forcing people to back up and fix these flaws in their digital workflow before really being able to move forward. I hope that's the case because the capability has been present for decades at this point, and I haven't seen anyone recognize that fundamental necessity.
Well, Ben, I really appreciate many insights you've shared with us that are really fantastic and thought-provoking. You've helped expand my understanding of not only your practice at vRad, but teleradiology in general. And I agree with a lot of what you're saying about our likely future in radiology. I think a lot of our listeners will also find this very interesting. If they want to learn more about vRad, how would you suggest they do that?
Well, I'd like to thank you as well, Matt. It's a real pleasure for me to be able to speak to residents in any venue, and so I really appreciate you taking the time. If people want to learn more about vRad, I would definitely encourage you to go to the vrad.com website. We offer free CME as well, and you can get a sense of the types of studies we read, and we even have video tutorials on workflow and the like. I'd also point you to our YouTube channel, vRad Radiology Education. We have about 4,000 subscribers there and post 15-minute educational videos every week or two. I'm actually coming up to our Las Vegas conference, which is March 8th, and we'll be recording those lectures and live streaming them as well. And we will be breaking those up into 15-minute videos and posting those on our YouTube channel. Lastly, I would tell everyone to please make an effort to sign up for our board review sessions. I do one or sometimes even two a year, and we have a massive Jeopardy board where we play a 4-hour game of Jeopardy, and the residents all across the country compete for a grand prize, which is a trip to Las Vegas for our conference. We also buy the winning residency a dinner of their choice. I'll actually call out the winners. We had UT Southwest, Loyola, Northwestern, and we have had SUNY Downstate, hi guys, win twice. It really is a thrilling competition. It's a great way to review cases of all types for your boards. And again, if you come to vrad.com and just sign up, create an account, and get on our email list, we'll let you know when those come around.
To clarify, if residents or residency programs want to participate in this Jeopardy, the best way to do that is to create a vRad account and then wait for an email, or is there another way as well?
That is the best way, is just to go to the vrad.com website and click on the Contact Us and create an account with your email, and then you'll be on our mailing list, and we can apprise you of upcoming residency review courses as well as the dates of our Las Vegas conference each year.
That's great. I didn't know about that resident educational board review opportunity, but that should be of interest to my audience, so thank you for raising that.
We've had as many as 400 attendees
Wow.
to those sessions. So they are incredibly competitive. People answer some of the most complex cases you can imagine in 20 or 30 seconds. When you get 400 radiology residents all prepared for their boards, everybody is just tuned and on the edge of their chairs. It's really an exciting thing to watch.
Thank you for letting us know about that. And with that, we'll end this interview. Thank you again, Ben.
Terrific. Thanks so much, Matt. It really was a great time.
Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.